So surgeon control planning for me is crucial because every time I do a preparative planning, I learn. And it's key for the surgeon to learn. Of course, we learn from our previous mistake, but here we learn from trial. And we can try different kind of glenoid implant, different size of sphere, different positioning of the sphere. We can also try augmented glenoid and see what does it change regarding the seating or regarding the range of motion. On the humeral side, also, we can see the influence of the level of the cut. We can see also the influence of the neck shaft angle on the range of motion. So, yes, there is definitively an impact of using Blueprint regarding the positioning of the implants.
So I like to use the aviation industry as an example. So no one would get on a plane with a 2% chance that it would crash. And yet the complication rate in shoulder arthroplasty is probably around that number if you're really good. When you do the surgery virtually, before you do it in the patient, you reduce complications and there's no question that you improve the outcomes. Now you improve the outcomes in several ways. One, you improve the decision-making process. Two, you improve the process itself. And three, you probably improve durability.
So, as you know, that's something I always teach to my fellows. There are 3 levels of competence if you want to be a surgeon. You have to be a stratege, like a general in the army. You have to be a tactician, like a colonel in the army. And you have to be a simple soldier to be able to have a gun and just shoot, you know. But when you're a surgeon, the most important is not the technique, as many of the young surgeons think. It's the strategy and the tactic. And Blueprint actually helps at the 3 levels. It helps you to choose the right implants for the right indication of the patient. It helps you to choose the type of implants, so the tactic basically. And then finally, it helps you for the technique when it provides you, for instance, patient-specific bone graft or patient-specific guides.
Blueprint has had a profound effect on my implant selection. Certainly, if you use anatomic total shoulder arthroplasty as an example, especially a B2 retroverted glenoid, typically I would have reamed the high side. And what Blueprint does is it places me at a higher standard. I have to now ream the high side. I can determine how much retroversion I have left. And if I can ineffectively correct it, I know I have the ability to switch to an augmented implant. And so now I have that in my armamentarium. And the same is true for reverse total shoulder arthroplasty with bone defects. Initially I would have reamed the high side, but now with Blueprint I can determine how much bone graft I'm going to need with bio-RSA, or if I'm going to be able to effectively do the reconstruction with a Perform plus reverse.
So Blueprint has changed my implant decision making by allowing me to manage inventory in advance of going to the operating room. I'd say the most important thing is that it allows me to know with a high degree of certainty what I'm going to use in each patient and the sizing. We've done some preliminary analyses looking at inventory management, and there's no question it has the potential to bend the cost curve by managing inventory. Now the staff is very happy with this because the number of trays that we require and the number of potential implants that we need goes down dramatically.
First of all, with Blueprint, I get 3D measurements for my patient, meaning 3D measurements of version, of inclination, and of humeral head subluxation. And that's the first major advantage. The second advantage is that with Blueprint, I can do a virtual implantation. And during the virtual implantation, I am able really to see how much inclination and how much retroversion I put to the implant. And the third impact of Blueprint is the dynamic testing of the range of motion, meaning that especially when I do a reverse, I check the range of motion and I check impingement during extension and external rotation in order to avoid the notching. And that is a unique possibility thanks to Blueprint. And for me, it's really crucial to avoid the postoperative notching with polyethylene wear debris.
I think Blueprint has completely changed my practice actually, because it has allowed me to choose the type of prosthesis I'm using, either a reverse prosthesis or an anatomical prosthesis. And if I choose a reverse, which type of reverse I should use, how much I should lateralize the glenoid, how much I should try to avoid lateralization on the humeral side. I mean, it has changed completely the paradigm for shoulder replacement, I think.
Blueprint has impacted my practice in that I can really plan for patient surgery, particularly in patients who have difficult glenoid deformities, patients who may be more stressful to treat when you're in the operating room because there's not as much bone to work with. It's wonderful to have a way to plan these cases beforehand, actually have the implant that you think you're going to use already in your mind and in the plan, and actually execute that plan with the help of a guide, usually, that helps you determine exactly where that implant needs to go.
Currently, I think that the guides are very helpful, especially for reverse, especially for severe erosion of the glenoid, either severe erosion in retroversion or severe superior erosion. The guides are really helpful.
So I believe that Blueprint will change the clinical routine thanks to preoperative planning based on artificial intelligence, to an intraoperative guidance thanks to augmented reality, and a huge community of users and experts who will share all their experience and knowledge in the field of shoulder arthroplasty. I believe this technology will be able to integrate all the data thanks to smart sensors and smart and connected implants that will provide more and more data, functional data and clinical data about the performance and the function of the patient after the surgery. So we'll get a global knowledge with including preoperative data, postoperative data, and intraoperative guidance.